If you or someone you love is relying on Medicare in 2026, there is a very real possibility that what you think your coverage includes is going to cost you far more than you ever anticipated. And in some cases, that miscalculation could drain an entire retirement in a matter of months. Medicare in 2026 is not the same system it was 5 years ago. There are massive financial shifts happening right now, some of them genuinely beneficial and some of them dangerous if you are not prepared. Today, every one of those shifts gets unpacked completely. The exact cost changes, the hidden coverage gaps that are catching people off guard, the nursing home trap that destroys family finances, what happens to your coverage outside the United States, and the smart tax strategies that can turn painful out-of-pocket costs into meaningful financial relief. The goal is simple: to make sure you are never blindsided by a bill you did not see coming. Section 1. The 2026 Medicare cost changes. Start with the genuinely good news, because 2026 is bringing some of the most significant prescription drug savings in the history of the Medicare program. Under legislation that finally gave Medicare the power to negotiate prices on certain costly brand-name drugs without cheaper generic competitors, 10 medications were selected for this first round of negotiations. They treat some of the most common conditions affecting older Americans: diabetes, cancer, rheumatoid arthritis, and heart disease. The savings are not marginal. They are transformational for the millions of people who depend on these medications every single day. Consider a few specific examples. The diabetes drug Januvia drops from a 2023 list price of $527 per month down to a negotiated price of $113. That is a 79% reduction, nearly $5,000 per year back in a patient's pocket. The heart failure medication Farxiga drops 68%, from $556 down to $178 per month. And Enbrel, used to treat rheumatoid arthritis, sees a 67% cut, dropping from over $7,000 per month down to approximately $2,300. For someone on a fixed income, that difference is not pocket change. That is the cost of rent, utilities, and groceries combined. Across these 10 medications alone, nearly 9 million enrollees are expected to save an estimated $1.5 billion in out-of-pocket costs in 2026. The second major financial win is the new annual out-of-pocket prescription drug spending cap for Part D enrollees. In 2026, that cap is $2,100. This number matters enormously because for years, Part D plans had no absolute hard ceiling. The infamous donut hole and the percentage-based catastrophic coverage phase meant that patients with severe, high-cost conditions could keep paying indefinitely. And many did, sometimes skipping refills or cutting pills in half just to survive financially. That era is over. Once you reach $2,100 in out-of-pocket drug spending, you are completely protected from any further prescription costs for the rest of the calendar year. Whether your medications cost $5,000 or $50,000, your personal financial exposure stops at $2,100. In retirement, that kind of predictability is not just a convenience, it is financial security. But the seesaw of Medicare finances requires balance, and while drug costs are being reined in, the base costs of the program are rising. The standard Medicare Part B premium, the portion that covers doctors and outpatient care, is increasing to $185 per month in 2026, a jump of nearly $18 from the previous year. Additionally, the maximum Part D deductible, the amount you must pay before drug coverage activates, is rising to $650. Because most enrollees have their Part B premiums deducted directly from their Social Security payments, these increases will directly reduce the net monthly income that reaches your bank account. Your Social Security cost of living adjustment may go up, but Medicare reaches in and takes a larger slice before the money lands. That give and take must be factored into your monthly budget planning for 2026. Section 2. Surprising 2026 coverage gaps. Many people assume that Original Medicare, Parts A and B together, provides comprehensive coverage from head to toe. It does not. It contains significant and costly omissions that affect the everyday health needs of millions of older Americans, and understanding exactly what is excluded is just as important as knowing what is covered. routine dental care is not covered. Cleanings, fillings, root canals, and dentures are entirely out of pocket under Original Medicare. Some Medicare Advantage plans offer dental benefits, but those plans typically cap coverage at $1,500 to $2,000 per year. Anyone who has needed major dental work knows that a single crown or implant can consume that entire annual cap instantly, leaving the patient fully responsible for everything beyond it. Routine vision exams and eyeglasses are largely out of pocket. Hearing aids, which can be critical for maintaining cognitive engagement, social connection, and quality of life, are not covered by Original Medicare, despite costing thousands of dollars per ear. And here is the coverage gap that surprises almost everyone. Adult incontinence supplies are entirely excluded. Medicare officially categorizes them as personal hygiene items rather than medical treatment, despite the fact that they represent a significant ongoing monthly expense for millions of aging Americans. There is also a new structural change that affects Medicare beneficiaries in 6 specific states beginning in 2026. A 6-year pilot program is launching in Arizona, New Jersey, Ohio, Oklahoma, Texas, and Washington. This program introduces prior authorization requirements for certain medical devices and procedures under Original Medicare, a layer of administrative approval that has not traditionally been part of the Original Medicare experience. If you live in one of these states, your doctor may determine that you need a specific procedure or device, but you will now need to wait for Medicare's administrative approval before receiving it. In practice, this means potential delays and additional paperwork between a medical recommendation and actual care. If you are in one of these 6 states, understanding this new layer of bureaucracy and planning accordingly is essential. Section 3. The Nursing Home Trap. This section requires slowing down and drawing a very clear line between 2 terms that are used interchangeably in everyday conversation, but carry dramatically different financial consequences. A skilled nursing facility provides short-term medical recovery care. This is the kind of facility you might go to for intensive physical therapy following a hip replacement, or to receive complex IV medications or wound care that requires a registered nurse. It is medically oriented and designed to help patients recover and return home. A nursing home provides long-term custodial care. Custodial care means non-medical assistance with the activities of daily living, bathing, dressing, eating, moving from a bed to a chair. These are not medical procedures. They are personal care services. Here is the reality that catches families completely off guard. Medicare never covers long-term custodial care. Not for a week, not for a month, not for any duration. Assuming that Medicare will pay for a nursing home if you or a loved one eventually needs that level of support is one of the most financially dangerous assumptions you can make in retirement planning. Even getting Medicare to cover a short-term skilled nursing facility stay, which it does cover under specific conditions, requires navigating a precise sequence of requirements that functions almost like an obstacle course. Step 1. You must have a qualifying 3 consecutive day inpatient hospital stay. 3 midnight stays. The day of discharge does not count toward those 3 days. Step 2. You must enter the skilled nursing facility within 30 days of leaving the hospital. Step 3. A doctor must explicitly order skilled medical care that you could not receive at home. Step 4. Medicare covers up to 100 days maximum per benefit period. Days 1 through 20 are covered in full. Beginning on day 21 and through day 100, you face a daily coinsurance charge of $217. After day 100, Medicare pays nothing. You are entirely on your own. There is a critically important threat built into this sequence that hospitalizes family finances every single year. It is called observation status. Imagine you are rushed to the hospital and spend 4 days in a hospital bed wearing a hospital gown, eating hospital food, with doctors running tests and monitoring your condition. You are then transferred to a rehabilitation facility to recover. Weeks later, you receive a bill for thousands of dollars from the rehab center. Why? Because the hospital classified you as being under observation status, rather than formally admitting you as an inpatient. Time spent under observation does not count toward the mandatory 3-day inpatient requirement, regardless of how many nights you actually spent in the hospital. If you or a loved one are ever hospitalized and there is any possibility of needing skilled nursing care afterward, you must ask the doctor or hospital administrator directly and explicitly, "Am I formally admitted as an inpatient?" Do not assume. The distinction between inpatient admission and observation status is not visible from the patient's experience, but the financial difference can reach tens of thousands of dollars. For seniors who need not short-term rehabilitation but long-term custodial care due to Alzheimer's, dementia, severe mobility limitations, or general physical decline, the financial picture is stark. The average nursing home in the United States now costs between $8,000 and $10,000 per month. That is up to $120,000 per year every year, with Medicare covering none of it. Unless you qualify for Medicaid, which typically requires spending down almost all of your assets to meet poverty-level thresholds, or unless you purchased long-term care insurance years ago, that cost comes entirely out of your own savings. For many families, it drains a lifetime of accumulated wealth within a few years. Section 4. Navigating care. Outside the United States, many retirees travel internationally, and the general rule for Medicare coverage abroad is straightforward and unforgiving. Once you leave the United States, your Medicare coverage stops. There are 3 narrow geographical exceptions. First, if you experience a medical emergency while traveling through Canada on a direct route between Alaska and another U.S. state, meaning you are simply passing through, Medicare may cover care in a Canadian hospital. Second, if you experience a medical emergency while in the United States but the closest hospital is actually across the border in Canada or Mexico, Medicare may cover care at that foreign facility. Third, Medicare may cover necessary medical services received on a cruise ship, but only if the ship is within 6 hours of a U.S. port at the time care is needed. Beyond 6 hours, you are on your own regardless of the medical circumstances. Outside of these highly specific scenarios, you need separate travel health insurance before leaving the country. Supplemental travel coverage is widely available and generally affordable relative to the risk it mitigates. Relying on Medicare while traveling internationally is not a plan. It is a gap. Section 5. Smart tax and financial strategies. After absorbing the scope of Medicare's coverage gaps, it is important to understand that there are real, legal, and accessible strategies for managing the financial burden of out-of-pocket medical costs. The most important of these is the IRS medical expense deduction. If your unreimbursed medical expenses are high enough in a given year, you can deduct them on your federal income tax return by itemizing. The rule is that you can deduct the portion of your medical expenses that exceeds 7.5% of your adjusted gross income. The math is straightforward. If your adjusted gross income is $50,000, your threshold is $3,750. That is 7.5% of $50,000. If you spent $35,000 out of pocket in that year on dental work, hearing aids, hospital coinsurance, and other qualifying costs, you subtract $3,750 from $35,000 and arrive at a deduction of $31,250. That deduction reduces your taxable income by $31,250, which can translate to thousands of dollars in actual tax savings depending on your marginal rate. What qualifies for this deduction? The IRS is relatively broad in what it allows. Your Medicare Part B and Part D premiums qualify. Out-of-pocket costs for hearing aids, dentures, and prescription eyeglasses qualify. Hospital services and coinsurance payments qualify. Transportation costs to and from medical appointments qualify. Even nursing home care qualifies. But only when the primary reason for residence is to receive medical care rather than custodial care. Custodial-only nursing home costs do not meet the qualifying threshold for this deduction. The practical implication is significant. By maintaining organized, complete records of every medical expense throughout the year, receipts, invoices, insurance explanation of benefit statements, and premium payment records, you can transform painful out-of-pocket costs into meaningful tax relief. The coverage gaps in Medicare are real and expensive. The tax deduction does not eliminate those costs, but for people with significant medical expenses, it provides a meaningful financial counterweight. Managing the nursing home cost. Your options. Given that Medicare covers no long-term custodial care and the average nursing home costs up to $120,000 per year, three primary planning tools exist for managing this risk. Long-term care insurance, if purchased before a health decline makes you uninsurable, pays a daily or monthly benefit toward nursing home, assisted living, or in-home care costs. Policies purchased earlier in life carry lower premiums. The window for affordable long-term care insurance is typically in your 50s or early 60s. Waiting longer significantly increases premiums or eliminates eligibility. Medicaid covers custodial nursing home care, but only after an applicant has spent down their assets to state-defined poverty level thresholds. Rules vary significantly by state, and the spend-down process can be complex. Working with an elder law attorney before a care crisis occurs, rather than during one, gives families far more planning options than waiting until nursing home admission is imminent. Medicare Advantage plans with supplemental long-term care or expanded home health benefits have expanded in recent years. While no Advantage plan covers custodial nursing home care comprehensively, some offer greater home health and adult daycare benefits than original Medicare. Comparing plan options carefully during each annual open enrollment period matters. The questions you need to ask. Right now, there are 5 specific questions every Medicare enrollee should be able to answer about their own situation heading into 2026. First, exactly what is my current Part B premium, and how does it compare to my Social Security cost of living adjustment this year? Second, have I hit or am I approaching the $2,100 Part D out-of-pocket cap, and do I know which of my medications are affected by the new negotiated prices? Third, if I live in Arizona, New Jersey, Ohio, Oklahoma, Texas, or Washington, do I understand how the new prior authorization pilot program may affect my access to care? Fourth, does my current financial plan address the possibility of needing long-term custodial care, and have I discussed this with my family and a financial advisor? Fifth, am I maintaining organized records of all my unreimbursed medical expenses, so I can take full advantage of the 7.5% adjusted gross income deduction at tax time? If any of those questions produced uncertainty, that uncertainty is worth resolving now rather than in a moment of medical or financial crisis. The bottom line, Medicare is changing in 2026 in ways that are both genuinely beneficial and genuinely challenging. The prescription drug savings through negotiated prices and the $2,100 out-of-pocket cap are real and significant for millions of enrollees. But the rising Part B premiums, the persistent coverage gaps in dental, vision, hearing, and custodial care, the nursing home financial reality, and the observation status trap are equally real, and they demand active, informed planning rather than passive assumption. The families that navigate Medicare successfully in 2026 are not the ones with the most money. They are the ones with the most accurate information, the clearest understanding of what their coverage actually includes, and a plan built around what it does not. You now have that information. If you have a question about how any of these changes apply to your specific situation, your Part D plan, your long-term care strategy, your coverage while traveling, or how to maximize the medical expense deduction, write it in the comments. Every comment is read and responses are given. If this was useful, please share it with someone in your life who needs it. A family member approaching Medicare eligibility, a friend navigating a nursing home decision, a parent who has never heard of observation status. The difference between knowing these facts and not knowing them is often measured in tens of thousands of dollars. Subscribe to stay current as Medicare rules, premiums, coverage decisions, and enrollment deadlines evolve through 2026 and beyond. When changes happen that affect your healthcare and your financial security, you deserve to hear about them clearly, completely, and in time to act. USA Claim Rights.